By the way, this the recording, because I'm using just this is not the like channel that my own channel in the what is it in the TA channel. So it's going to be recorded in the it's going to be uploaded in my this chat box in the Teams. So I'm not sure whether you can access it easily. So what I do is like I download it and then I upload it to the my YouTube channels. Okay, so I will at the end of the session I will just send the link so you can if you wanna watch it later, or if you wanna, send the link to someone so who didn't attend the lecture, so you can do that. Okay. All right. So I'm gonna start sharing screen. So by the way, where are you guys calling? Where are you right now? Obviously, you guys are at home right now, right? Hopefully. So where are you? I mean, the locations. I'm in New York. I'm in New Jersey. Where are you guys? You can, if we don't talk, then you can just write down in the chat. Where are you? Where are you? I mean, in terms of, say, time zone or, the location. Can you hear me now? Hello, can you hear me? Can you hear me now? Hello? Do you see the chat box? Hello? Do you see the chat box? Oh, can you hear me? What's wrong with this thing here? Can you hear me? Hello? Um, Hello? Do you see my screen? Can anybody tell if it's do you see screen? Hello? 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 Do you hear me? What's wrong with this thing here? Hello? Uh, can you hear me, or can you respond? Is it um? Oh, okay. Yeah. So you can hear me, right? Okay. All right. I mean, I was wondering, because you didn't have you didn't have any response. Okay. All right. So because we are not like many people, so if you feel free to uh just unmute and talk if you like to, if you have any questions or if you have any concerns. Okay. All right. So today is the last day, so I'm gonna do in the first session. I'm gonna do the endocrine, and then the next session at 1 o'clock we'll do the reproduction. Okay. All right. So there are like many pages, 90 pages, but this is a kind of condensed. So so I will cover the like highlighted part only. Okay, so I will just highlight the what you need to do. I mean, what you need to know, and the because they say this is obviously covering whole endocrine in 2 hours. It's impossible. So I'll just try to highlight the sections that you really need. Okay, so this is like basically the in terms of the contents in the PPT. That is say about 50% of about 50% of contents what you need to know in the endocrine. But I will maybe go over only some part of it, so which are like very important. Okay. So if I don't cover it, and then just read through this the slides, and then also if you have a boot camp, then I highly recommend to uh, go over this the slide before the semester starts. So it will make the semester much easier. Okay, so boot camp is the one that the materials that this slide was the cover come from. And I highly recommend this getting a boot camp. It's a really good source to basically to study along with the lectures. And I think this is a kind of new. They maybe came out like maybe 2 years ago, something like that. But it's really nice tool. Okay. All right, so I'll just try to highlight the sections that is really needed in the endocrine. Okay, so basically this page is basically all kind of definitions. Autocrine, paracrine, endocrine. What does endocrine mean? Yeah, endocrine means endo. Whenever you see endo, think about the blood. Epi, think about some tube, meaning that the blood vessel has a, this is a blood vessel that has a like wall, right? Blood vessel wall, right? These are the endothelial cells, okay? And then if there's a tube, for instance, the kidney proximal convoluted tube, or any kind of tube, GIT, or the bile duct, or any kind of the urinary tract or that kind of things, right? That other than tubules, other than blood going through, there's the tube that has also the cell wall, right? This cell wall is epithelial cells. Okay, so epithelial cell and endothelial cell. That's very important to the distinguish. So we learned in the linear section, right? So this is the basement membrane. So say this is the urine side, and then this is the blood side. So this one here is endothelial cell, and then this is this kind of the membrane. Membrane is kind of fascia, okay? It's a fascia that is basically this is a kind of the kind of fascia, right? And then on top of this, there's another layer of cells, which is the epithelial cells. In particularly in the renal glomeruli, this is called, another name for this is a podocyte. Okay, podocyte, epithelial cells, which is in the tube. Tube means that where the non-blood the materials go through, like this. In this particular case, urine is going through. Okay, that's the podocyte, epithelial cells, and then here where the blood is going through, is the blood is going through here. That's the endothelial cell. Okay, so in other words, in here, endothelial endocrine means that blood, so hormone is just going through the blood. So that's why it's called endocrine signaling. Paracrine means it's just next to. Paramedic means next to the medic. Medic is the doctors. So next to the doctor. So like EMT, the I think sometimes the nurses or the PAs, the NPs, those people are called paramedics. Okay, and autocrine is like self. It's just the like signal self. Okay, all right. That's this is just the definition, but you need to know this thing. And then exocrine. Exocrine is something uh, uh, like going outside. So, for instance, the like sweat. Sweat is like going secret to the outside, right? Also, like milk, outside to secret outside to the body, and saliva and that kind of things, right? Or vaginal, the vaginal fluid, vaginal lubricant, or that kind of stuff. That's going to the outside, all right? So outside, in the thing that you need to understand is that outside, what do you mean by outside body? So outside body. For instance, pancreas is exocrine and endocrine, two the kind of dual functions. Okay, so what endocrine, we know that, right? Endocrine, it makes the like insulin and the somatostatin and the glucagon. That's endocrine, right? Because it will go through the when you secrete this from the pancreas, it will go through the blood vessel and then going all over the body, right? And how about exocrine function? Exocrine is not necessarily you look at from outside of the body. I mean, uh, like what I'm saying is like even if looks inside of the body, actually it's outside. For instance, GIT. Is GIT inside or outside the tube tract, or the bile duct? Is it outside or inside? Can anyone tell? Is GIT inside or outside body? Any answers? Tony? Yes. Is it inside? GIT is inside? Okay, let me tell you why this is not inside. Okay. Yeah, it looks inside because this is a human being and something inside, right? But it looks inside, but actually it's outside because what happened is here. I'm really bad in the drawing. Okay. So this is the human here, right? And here is a mouse. Okay. Mouse goes here. So mouse is basically outside, right? Because connect to the air, right? Air, it goes inside and then goes out, the anus. So there's a like hollow tube, right? So then now I give you this hint. Is it inside or outside? It is tube, so external openings. Yes, yes. It is tube, so external openings. That means outside. That is considered as outside. Okay. Although it looks inside, but it is actually outside. Okay. Very important thing in terms of the uh, female reproductive anatomy. Vaginal opening. Okay. Vagina, is it inside or outside? Vagina is the same, by the same token, it's outside, right? Is there anything that is very, very ambiguous, whether it's inside to outside. The only exception is the vagina. The vagina is like this, and then the cervix is like this, and then uterus right there, right? And then there's a fallopian tube, right? There's a fundus of uterus, fallopian tube, and then there's the kind of fimbriae. Fimbriae is kind of arm, I mean the fingers, and fingers here, and then the uterus here, right? And then vagina here, right? All right. Now there's an ovary right here, right? Ovary, and then the uterus, I mean the fimbriae. How does it connect it? What happens is ovary release the egg, right? Egg comes out. This fimbriae will grab it. Actually, it will literally grab it and then bring it to the uterus. Okay. This area here to here is outside, right? This is outside. This is inside, right? This opening here. So if you theoretically, we don't do that now in the current medical technology. We don't do that now. Theoretically, if you insert some kind of tube here and then tube here and then come out here, this will connect to outside to inside. This is inside body, right? There's an opening here. Basically, this opening is a connection between outside to inside. So imagine your mouse. Mouse is connected to the all the way connected to the GIT, and then it connect to the anus. There's no opening in here. There's no opening. It doesn't leak out. It just basically through the tube, right? Now then, this one is not a tube. It's just an opening. Basically, opening here, and then the opening here. This is the vagina, and then like orifice for the vulva orifice. Okay, and then this one is opening fimbriae, and then ovary is right here. So this is like basically tube is not the connected. Normally this tube, all of the tube is like kind of the opening, and then the openings are like through the outside, like mouth, and then this is like anus, right? But here opening is when you go out of the tube, it will be outside, right? Here go out of the tube, outside. But now here is inside, and then this is outside. I mean, this is sorry, this is outside in terms of the vaginal then fallopian tube connection. This is outside, and then this is inside. Okay, that's the only exception that has a like although it's inside, I mean although it's outside, considered as outside, but its opening is one side is inside, and then the other side is outside. Okay, so that's kind of something you need to consider. Okay, anyway, that's the little detail deviation from the anatomic perspective. All right. And then the other things are not very, very important. Okay. And the one big big organ in terms of endocrine is a pituitary. Okay. Basically, you need to know the hypothalamus, pituitary, and some end organs. Okay, for instance, it can be end organ means like thyroid or the adrenal gland or like testis or any pancreas. All those are kind of hypothalamus, the pituitary, and then the 1, 2, 3. 3 can be the adrenal gland or pancreas or kidney or testis. All those are the kind of third level. Okay. So first level, second level, and then third level. Okay. So now then hypothalamus is considered as like basically commander or master of the endocrine system. And then like pituitary is kind of, executor. And this is like end organs. Okay. So actors. Okay. So now then the hypothalamus makes many the hormones, and then that will be secreted through the pituitary. Some of the hormones are like that, and some of the hormones, uh, hypothalamus will secrete the releasing hormones. For instance, gonadotropin releasing hormone, or the corticosteroid releasing hormone, and the what else? The thyroid releasing hormone. The releasing hormone, when you see the releasing hormone, that's a hypothalamus. And then pituitary will secrete the stimulating hormone. For instance, thyroid stimulating hormone, and the follicular stimulating hormone. Okay, those are kind of releasing hormone, stimulating hormone is a pituitary, whereas releasing hormone is a hypothalamus. Okay, and then third level, the end organ will just make the hormones according to the first level, which is hypothalamus, second level, which is pituitary. Okay. Now, important point is that negative feedback. What does negative feedback mean? 1, 2, and then third level, right? So this will normally the order is that this will stimulate this, right? This will stimulate this, and then the hormone comes out, right? So now negative feedback means this one, when hormone level is too much, right? If it's too much, then it will negative feedback to this. So if, for instance, if the too much gonadotropin, I mean, if the too much testosterone, then that will inhibit to the pituitary level. Okay, yeah, I have too much testosterone. Please don't make it. Don't make any more the testosterone. Don't make don't stimulate me. Okay, that's what that means. Don't stimulate me. Then now this one also the stimulate. I mean negative feedback to the hypothalamus. Don't make the releasing hormone so that the pituitary don't make the stimulating hormone. Okay, so don't make the FSH. Don't make the gonadotropin releasing hormone. Okay, so that's what the feedback is. Normal, this is normal situation. So normal situation usually, usually in the exam, in terms of exam, normal situation is usually not very high yield, but mostly high yield is like what that's the normal situation. But when there's an exception, that's a very good topic for the exam. Okay, for the exam purpose. So you need to know when there's an exception, you need to know that, okay? So I will come back later for this, what are the exceptions? Okay, for instance, the estrogen and inhibit. So this is like the end organ level, right? And then this is a pituitary level, and then this is the hypothalamus level, estrogen, and then there's a like inhibin. Those have a like different the kind of sometimes it will inhibit only pituitary level, and some of the hormones will inhibit both pituitary and the hypothalamus both. Okay, so those things are that you need to know as it come out. Okay, all right. Another thing you need to know about the pituitary is that pituitary release the flat pig. You know this flat pig, the flat pig without eye. That's what the pituitary released. So flat pig means that FSH, LH, HTH, TSH, and then the prolactin, and then growth hormone. Okay, flat peak, no eye. Okay, so those are the hormones that is released anterior pituitary. There's a the pituitary has like a anterior and then posterior. Okay, that's anterior, and that anterior hormone, the anterior pituitary is let me see. Can I? Where's my okay? Just a minute. Okay, so anterior pituitary has a different embryological the development than posterior pituitary. Posterior pituitary actually coming from the neuro. This is the purely endocrine. So the what's the structure that like kind of give rise to the anterior stalk of the pituitary? What's the other one? What's the posterior pituitary coming from? Anyone tell? Anyone know? Have you heard of this one? Raske pouch. What's the Raske pouch? Can anyone know? Can you tell me what's Raske pouch? Don't know? Okay, Raske pouch is basically for like previous. I mean the that will develop the Raske pouch will develop to the anterior pituitary, and then it will be called as a infundibulum. Infundibulum, or there are few names like tubular infundibulum or something like that. Okay, so those are the kind of anterior pituitary, and then whereas the posterior pituitary is a neurological structure, so neuroendocrine. So it's like a different mechanism basically. Okay, so so that's why the posterior pituitary is not really anything the making anything. Posterior pituitary is basically the storage organs. Okay, posterior storage. So what two hormones are stored in the posterior pituitary? Okay, so what's the two? And can anyone tell the which two hormones are secreted from pituitary? I mean posterior pituitary, ADH, and what else? ADH is one, yes, good. There are two hormones. The other one. What's the other one? ADH and then oxytocin. Yes, good. So there are two. One very important thing about the oxytocin. There are two mechanisms. Most of the in our body is the regulated by negative feedback. Negative feedback means very simple. If there's too much here, then it will negative feedback. Oh, don't make me, don't make like my, don't make my hormones, because I have too much the hormones. So please don't make it. So that's negative feedback. Okay. Now then, there are very few cases. Actually, I know only two things. That is only the exception is the prolactin and the oxytocin, especially oxytocin. Okay, is very important. So how the in oxytocin has basically actually in two instances, oxytocin gives the not not follow the negative feedback, but positive feedback. What does positive feedback mean? It's simply like this. This is end organ, and then this is like the commanding organ. So like pituitary or hypothalamus, right? And what happens is if there's like too much here, right? Then normally don't make it, right? Now this positive feedback means it will, if we have the something here, then that will positive feedback. Okay, make it more, make it, yeah. So I have some other hormones. Now make it more hormones to me. So that's what the positive feedback means. That's kind of nonsense, right? But it occurs only in the two important instances: prolactin and the oxytocin. In oxytocin, what happens is this thing. Um, let me see. Let me just admit her. Okay. What happens is when you have the like delivery, right? So uterus, this is a uterus, and then this is a vagina, and then uterus will be just the stimulating, right? So baby head will come down here, and then the uterine will be kind of relaxed, right? And the uterine has to be contract so that the baby can pop out, right? So what happens is when the baby touches this the kind of touchdown, so touches this line, which is like this is a and like endocervix, and then this is endocervix, and then this transitional zone, right, and then ectocervix. When baby head touches this here, this is a line like a endocervix or ectocervix in that transition zone. It will stimulate the oxytocin. It will secrete oxytocin first at the beginning. It will secrete oxytocin. When oxytocin secreted, that will positive feedback to the pituitary and the hypothalamus, making more oxytocin. So when as the oxytocin comes in at the beginning, it will positive feedback to the hypothalamus to make more oxytocin, more oxytocin. So more oxytocin comes in, and then it will continue to stimulate more and more. So uterine will contract very the like often. So frequency becomes the very fast frequency, and then stronger frequency. So it contract more and more so that the baby can come out easily. Okay, so that's what the oxytocins, oxytocins, positive feedback function. Another example is this is kind of the 19 how do you call that, like when you rated, say rated R, rated X. Okay, so this kind of version. So what happens is that when you have the female has the orgasm, right? So what happens is when the uterine, it will also, the oxytocin will come out. Okay, oxytocin will come out. Then the uterine wall will be stimulated at the beginning, and then in female case, it will be more and more oxytocin will be the positive feedback to the uterine. So that's why female has a stronger and then the long lasting the orgasm. And then even after that, he will, even that the stimulus stops, it will stimulate more. So it gives up. That's why the female can have the multiple orgasm. All right, that's one of the example for the oxytocin. And second example for the prolactin is when baby suckling. Okay, when baby suckling, the nipple here, that is the breast, and then when baby suckles, then this will stimulate to the oxytocin and the prolactin. So making more the blood. This by the way, prolactin makes the blood, produce the blood. I mean that produce the milk. Okay, to produce the milk, secretion is from the oxytocin. Okay, so it will stimulate both oxytocin and then prolactin makes more and more the milk. Okay, so oxytocin will stimulate more, so it will just contract this the duct, lactating duct, so milk can come out more. And then also at the same time, the prolactin will be stimulated, and by the following the positive feedback group, so it will make more milk. Okay, so this is how that the positive feedback works. So because this is an exception, so also this very important exceptions that in terms of feedback group. Okay, another important thing you need to know is prolactin. Because what happens is prolactin, I mean, not the exception, but the important thing in the endocrine. Okay, so prolactin is the it's kind of the in the pituitary about same uh in terms of size. Normally it takes about same size, but problem is prolactin is the most sensitive outside of outside of stimuli. So what that means is that when there's something strange thing happen, or something some kind of stimulus, prolactin, I mean the prolactin gland is the most sensitive to grow or to shrink. So prolactin becomes, when there's some stimuli, prolactin becomes a growing big time, and then whereas the other ones not stimulated yet. So prolactin, that's why prolactin gland will be the first one to grow, and then it most likely, if there's like the pituitary gland, there's like the seven, I mean six, anterior pituitary has a seven kind of glands, right? Subgland, which is one of them is prolactin, the other one is like the acetylcholine, I mean HTH, and then FSH, LH, and those things, right? Prolactin gland will be becomes the biggest growing. So that becomes the anterior, normally anterior, like anterior pituitary is this big. And then when there's some other stimuli, outside stimuli, either malignant or non-malignant, if there's a stimuli, then prolactin gland it becomes big, and then the other gland remains about same. So this is what happened. So prolactin, and then prolactin gland becomes big. What's going to happen? You have a prolactin level will be high, right? Because prolactin gland secretes prolactin, of course, obviously, right? Prolactin becomes large, the big. Then what does prolactin do in terms of the say erectile function, sexual functions? Prolactin has a do you know the lactating contraception? Because it's important, I will just write it here. Lactating contracept. What does this mean? Lactating contracept. What lactating? So contracept, you know contraception, right? So lactating contraception means that when you have a baby, when you are feeding breastfeed the baby, do you want to have a like more more baby? So you want to make more baby while you're the lactating? Yes, that is a natural birth control. So God made the female. So basically God gives some break to the female. So if we are lactating, okay, so you just focus on this first baby. Don't make the second baby yet. Okay, that's a kind of a natural birth control. Although it's not 100% working properly, but that's the idea. Okay. I mean, so you don't see I mean, there are some people, because there's always an exception. You don't see your siblings are not less than like the say 12 months old, 12 months apart, it's very, very hard to see. Some people do. I mean, some people. I know even some people whose siblings are only less than 11 months apart. But that happens. But even if her mom was the lactating the baby, her sister was only less than 11 months old. But exceptions are there. But like a big general idea is like the natural birth control. Okay. All right, so that's the lactating control. So what I'm saying is that if you are the lactating, then that will feed back to the FSH. So milk will feedback to the negative feedback to the FSH. So basically milk is a prolactin, right? So prolactin will the FSH, the negative feedback to the FSH. So no testosterone, no estrogen comes out. So you don't the like you don't have mens because ovulation is not there. Okay, so that's the like lactating contraception. Okay, so what happens is when the FSH is not working, you basically in terms of the female, it will be on ovulation, right? No ovulation. But in terms of male, it will be basically the gonadotropin is not there. So in other words, the gonado the hormone, gonadic hormone. So for instance, the testosterone is not there. So no testosterone, no erection. So that's why you have a ED. Okay. So when you have the prolactin level too high, erection, the erectile dysfunction occurs. Okay. So another like application for this was dopamine and then prolactin level. This is a very, very, very important topic. It will be appearing for sure in the case, for sure in the step one, many, many different ways of the testing this concept. Okay, so this is very important. So listen very carefully. When the dopamine level is high, what's going to happen? What kind of thing, if it's too much, what kind of disease do you have? If it's too little, what kind of disease you have? First, if it's too much, then what kind of disease do you have? If dopamine level is too high, Parkinson's is too much. No, actually opposite. Parkinson is like dopamine is too low. Okay, so this is important. I will just write it here. Dopamine too high, too little. Parkinson's too high is what? Yeah, product, yes, true. But I'm talking about dopamine. Okay, dopamine level right now. Dopamine level is too high, then it will be the psychosis. And then dopamine level is too little, it will be the Parkinson's. Okay, so psychosis means the schizophrenia. It's a schizo. Okay, so what happened is dopamine inhibit prolactin. Okay, so if you give like in order to treat psychosis, in order to treat the schizophrenia, what you need to do, because you have too much dopamine, right? So you are trying to decrease the dopamine level, right? So you give the antipsychotic, right? You give antipsychotic is basically we will decrease the dopamine, right? If we decrease the dopamine, what's going to happen? If you decrease too much, then the Parkinson's will occur, right? So that's why you have to, or and yes, true. And then that's absolutely true. And then if you are trying to treat the Parkinson's, and so Parkinson's is because of the too little dopamine. So now you are trying to add the supplement the dopamine, right? So you give too much dopamine. What's going to happen? You will become psychosis. You will become schizophrenia, right? So you have to balance very, very carefully. Theoretically, if if you have like very, very effective and very accurate the drug, normally, I mean, what your intention is like the because they have a different pathway. For instance, nigrostriatal pathway, there are like five the dopaminergic pathways. So there are like the nigrostriatal pathway, there are infundibulin pathway, mesolimbic pathway. I think there are there are two more. I don't remember. Anyway, so the nigrostriatal pathway is for the Parkinson's. The mesolimbic pathway is for the psychosis. No, I mean if the drug is working really perfectly, then you develop the drug that works only through the Niagara steroidal airway. I mean the pathway. So then only works in it will treat Parkinson's, but it doesn't go anywhere else. And 100% working here. That's the ideal scenario, but it will never happen in real life because of you cannot make like 100% like goes here. It will just go to the other pathways too. Okay, that's the problem. So understanding this relationship is very, very, very important. Okay, so what's the problem with dopamine and then prolactin? Prolactin, dopamine. Basically, you can think that prolactin and dopamine are kind of against each other. So let me write this way. Prolactin, dopamine is kind of this balance. It's supposed to be balanced like this. Okay. So if prolactin is high, dopamine is low. Dopamine is high, prolactin is low, like this way. Okay. So this balance is very, very important. So whenever prolactin goes up, dopamine goes down. Prolactin goes down, dopamine goes up. So this picture is very important. So prolactin, when think about this, you learned about in year one, I think, right? And when you give some the antipsychotic, let me see, you will learn this in year two, I think, right? Year two, is it year two? I think in year two. I mean the med two, I think med two or med one. I'm not sure. I forgot. But the when you give the too much the antipsychotic, that will give the that will give the like antidepressant, that will give the like the ED, right? Antidepressant or the antipsychotic. So what happens is the dopamine will that's one of the side effect, right? Because dopamine has this because of this relationship. All right. So you have to know this one and then this one very, very carefully. Very, very important. This will definitely, I can guarantee this will be on the cast, and then this will be on the step one, and then many, many different ways. Minimum this, any if you know this relationship, you will get minimum like maybe 10 questions, I guess. Yeah, in the real step one. Because it's so important, and then there are so many ways they can test you on this same concept. If you know this, all you need to know is prolactin, dopamine, the opposite, and then the dopamine has like an effect on the psychosis, and then the Parkinson's. So they can just make many, many, many ways. It basically it'll all, no matter how they ask you, it'll all boil down to all you need to know is this. this, and then this. Those two will be, that's what they are going to ask, but they can ask you in many, many different ways. They can ask you like 1,000 different ways. So all you need to know is that how to like extract what they are asking. Okay, so very, very important concept. Okay. Okay, another thing is that prolactin, because like I said, prolactin is the first one to the most sensitive one. So in other words, when there's some kind of stimulus, prolactin grows big time. When the prolactin grows big, I mean the prolactin gland will grow big time. So when it grows, it can grow either. So this is like the pituitary, normal pituitary gland. It will grow this way or this way, right? It grows normally. Normally, if it grows like about say 70% of time grows in this way, 30% of time grows in like laterally. Okay, so if it grows the anatomically, if it grows in the kind of vertically, what's going to happen is this one is a celatoschica. Celatoschica is like kind of this part is a celatoschica. This is if you look at it from the side, it's like this. Ceratoschica is basically a kind of bone, okay? So you cannot, go down. It has to go up, right? So it grows up. Then it will, on top of that, there's a optic chiasm. So if you press the optic chiasm, what's going to happen? You know this one? Uh, Here like this. And then the crosses here. So this is optic chiasm. So if I draw it in this area here, so like this. This is optic chiasm. So yeah, pituitary hematoma, that'll be the hematoma. You mean hemianopsia? Bitemporal, not the hematoma. Bitemporal hemianopsia. So bitemporal, yeah. So yeah, yeah, I understand what you mean. But it's the hematoma is a different thing. Hematoma, yeah, that's yeah. So hemianopsia actually. Anop SIA. Okay. Anyway, so this will, so basically, let me just a minute. Let me just admit him. Okay, where is my? So what happened is this thing here, this crosses, and then this thing right here. So here, right? So if you like optic chiasm is writing right there. So it will what areas will, if you block this, then what's going to happen is that this will, what you see is going to be, this side will be seen in here, right? So this subject in here, sub object in here will be seen inside of this other area, right? So if you block this, then this outside part, which will be what's in here, is okay. But whatever the image projected to inside of eyeball, like kind of middle side of eyeballs, that will be blocked, right? So what you are seeing in the screen, say this part is blacked out. If you are seeing, like, say for instance, the person will be like this, right? So this is like screen, then you will not see this part. You will not see this part. You will see only middle part. That's called bitemporal. Temporal things. You have a eye here, then temporal. This is a temporal, right? Temporal. Bitemporal, by both sides. Bitemporal because half anopsia. A, not nopsia. Nopsia. You cannot see. Bitemporal, both side, temporal side. not the node nasal side. Temporal side you cannot see. That's why it's called bitemporal hemianopsia. Okay. I said that just to recognize it on the yeah, that's correct. Yes. All right. So, I mean, I don't really care about the like spelling, and then I'm very very bad speller, and so what I do is like 99% of 99 time you are okay, because even if you just you forgot how to spell exactly, that doesn't really matter because it's a multiple choice. That's a like big advantage for multiple choice questions, because the answers are there. They don't really trick you about the spelling. No, it's no way that they can trick you about the spelling. Just don't worry. Only one instance that you need to know about the distinguishing between median ligament. Maybe that's the only thing. Other than that, I don't see anything. They care about the spelling. Okay. Anyway, so that's the thing you need to know. All right. And another thing is that if I say I said like it can grow vertically and it can grow the laterally too, right? So what if it's laterally growing? What's going to happen? What are you blocking? The optic chiasm here, right? Pituitary gland here. If it grows laterally, what's going to happen? What are you blocking if it grows in the laterally? Where is the here's the pituitary gland, and then what's in the side? This is less common than optic chiasm blockage. Okay, optic chiasm compression, less common, but it's does anybody know what's in the lateral side of the pituitary? Do you know carotid sinus? Carotid sinus has a uh, colossum. Yes, true, but that's not exactly right next to it. Okay, here is the carotid sinus. Okay, so this carotid sinus has a carbonosum. Carbonosum? Not really. No, actually, carotid sinus. Okay, carotid sinus is the one that is like this. And then there are. Do you know that's like the three, three, four, three, four, six, B1, B2. Anything ring the bell? Six. Where the six is here? Yes, this is what it is. So what happens is it will grow laterally, and it's like this. The arrangement is like this. So if you laterally, it will first affect this the sixth first. And then if you grow further, then it will affect all the other thing. Okay. So cranial lobe. This is the carotid sinus. Normally, this is happening for the carotid sinus hemorrhages. When there's a hemorrhages, it will block this thing, right? When there's a also it can happen in when the pituitary grows big time. Okay, when it grows in the lateral side, all right? That's less common, but this is more common for the optic chiasm compression. It's more common. Okay. All right, let's just keep going with the other. Actually, I think we spent really big time about the SIDH, so I will just skip that part, okay? And this is like one of the kind of this thing, hyponatremia caused by SIDH. So SIDH, the euvolemic hyponatremia, okay? All right. And this one is embryology, so that you need to know the Lasky pouch thing, right? So we already discussed this, right? That's basically hypothesis is basically the same thing. This is coming from the hyper. adeno hypothesis. Adeno simply means, I mean, when you have a like new terminology, right? So just to digest the wording, adeno simply means gland, right? Hypo means like, of course, low, and then physis is like, physis is the pituitary, same thing, okay? The physis, pituitary, neuro, hypo. So something to do with hypothalamus, then neuro. Okay. So, when I see I mean, my the native tongue is not English. So when I see new terminology, I always digest break down the wording. Adeno hypophysis. Okay. Neuro hypophysis. So that's how I do it. So, whenever, it's a lot of, there are a lot of very many the new terminologies, right? Medical terminologies. Medical terminologies are very easy to digest because, you just break down the wording. It's very easy to digest. Even the like drug names, right? Drug names are very like imitinab. If you know this like wording, it'll it'll be much easier for you to the like digest the. I mean, you will just guess. Oh, yeah, what kind of drug it could be. For instance, imitinab, imitinab. So TI means a tyrosine kinase inhibitor. Okay. IMI is like something like this is kind of, basically, when you make something, this is a real name. Okay, the real name, natalizumab or imitinab, adalimumab, those are kind of, their own some kind of their real name, and for unique for all kind of drugs. And then this is what the hydrogen kinase inhibitor means. And then this is like monoclonal antibody, or that kind of thing. So you digest the wording, so you will at least guess what kind of drug could it be. Okay, so when you kind of put it, or you get the ACE inhibitors. It's similar concept. Okay, all right. So I just already explained these right things, right? So the very important concept is a prolactin regulation. Very important concept. Okay, dopamine and prolactin. Very important concept. It's a guaranteed the question in the exam. So also I explained this thing, suckling, and then also didn't explain about the uterine contraction also, but that has been included too. Uterine contraction also, the rated R, rated X type of the multiple organism and that kind of things. Okay, another important thing is that gigantism and acromegaly. What's the problem here? GH is a problem, right? GH, it is true, but GH is the problem, but GH is not really an actor. It's not actor. What really work kind of like executioner or actor is like the like basically the how to call that, like the not the handyman, the hitman, yeah, hitman. Hitman is the IGF. So IGF-1 is a hitman. Kind of the GH is kind of mastermind, commander, right? So GH is the order. Okay, so grow something. Then what really works is the IGF. So look at this wording: insulin like growth factor. Isn't this something strange? Why insulin all of a sudden? So because remember that insulin has two big functions. One is glucose, something to do with glucose. The other one is anabolic function. Anabolic simply means growing. Okay. anabolic function and then glucose control. That's the two big functions of the insulin, right? So insulin's the anabolic function is what is done by IGF-1. So if there's something wrong with the growth hormone, so if you have like say excess growth hormone, what's going to happen? It will. It's not really the GH. It could be GH function, GH too much GH growth hormone. That's also one factor, right? But also it could be the IGF-1 is like working too much. If you order, yeah, can you grow that tissue? And then, but IGF is working okay, then IGF working like too much, some kind of malfunctioning. Okay, so can you grow this tissue by like 10%? And then IGF works, okay, sir. And then he will work really, really hard. And then instead of growing 10% only, it will grow like say 70%. So that's the problem, right? So, but more times IGF is like the functioning too much. Okay, so that will cause the gigantism too. Okay. So what's important thing is that when it's like the when you are young, when the before epiphyseal the plate epiphyseal plate close, so this is a epiphyseal plate, right? So if this close, if we, I mean, before this close, then if the insulin, I mean growth hormone is like too much, then it will make it long bones growth. So long bones grows, then this long bones will grow big time. So that's why this guy is like super big, right? So that could be good. That could be good, right? It's a, I want to be taller, right? So, but if the insulin excess happens after the epiphyseal plate closes, then long bones cannot grow anymore. So it will grow something else, not long bones. So for instance, like your jaw or your the vertebra, or not only the like bones, but it can grow some other organs too. And particularly important is a cardiomegaly. Why the growing cardiomegaly is a problem? By itself is not really a big thing, but problem is, um, what about the disease you see, right? What they will ask the in the exam, and then in even in the clinical scenario, what's the most important thing when you see the new disease? What can kill you? Okay, if he has like some, so in other words, for instance, in the growth hormone case, what can kill you? Cardiac tamponade. You can kill many things, many problem with the cardiac, because the cardiac heart is too big. So it can kill you in many different the complications from the cardiomegaly. Cardiac insufficiency, possibly. Cardiac tamponade, possibly. Myocardial infarction, possibly. Whatever the reason, that will cause the death. Okay, so what can kill you is the most important complication of the any type of disease. Decreasing stroke volume over time, must possibly, because it depends on cardiac muscle is right there. If it goes eccentrically, it can grow eccentrically, meaning that this is the cardiac muscle, for instance. This is cardiac wall, and then if it grows like the like this, so eccentrically, so then about same thingness as the original. This is normal. Eccentrically, then it becomes like this. Then what's going to happen? If it becomes like this, then a lot of preload, right? A lot of preload. But then you cannot handle the thin this muscle thickness cannot handle this the very, very heavy preload. So this is problem with the systolic or heart failure. Yes, yes, true. Heart failure, systolic heart failure, or if it's eccentric, eccentric means outside, right? Eccentric, the cardiomegaly. Then is it going to be systolic failure or the diastolic failure? Is it the filling problem or pumping problem? Very important thing. If it's too big, eccentrically too big, very, very important. Are you sure filling problem? Pumping problem, yes, yes, yes. Because of yeah, if it's not okay, yeah, very important. This is very, very critical point. This is a really, really important point. If you don't understand this, you have a serious problem in cardio. Okay, so what happens is normally think about this. Normally this thick. So if it becomes this big, same thickness, or sometimes even thinner, because what happens is this in eccentric parallel. The sarcomere will be parallelly added. Okay, so this one has a record. Say, for instance, here is a 10 sarcomeres. This one has like maybe the 20 sarcomeres in parallel. I mean, sorry, what am I saying? Series, sorry. In series. So here, 20 of them. Here is only 10 sarcomeres in a row in series, right? So what's going to happen? This is like a, about same thickness, or maybe even thinner. Okay, so thin cardiomyocytes, right, will try to pump this one. Thin means like, think about this. This muscle one, this is muscle one. This is a muscle. Sorry, this. Muscle two. Yeah, let me redraw it here. Muscle two is this. Okay, so thinner muscle fibers, and then this is the thick fibers. And then which one is stronger? Of course, this is stronger, right? And if you have a like stronger means that you can push more, right? More strong. So this is like weaker, right? So you cannot push the big load. Only the weaker. So means that you cannot handle this big the preload. So this is like nothing but Frank Sterling force. So you cannot push the big you cannot pump the big load of the preload. That's the eccentric heart failure. Sometimes it's called systolic heart failure. And then very, very technical name for this is heart failure with reduced ejection fraction. So oh shoot, oh my God, what happened here? Yeah, sorry. The heart. Yeah, it's called heart failure with reduced ejection fraction. Very, very important. Okay, heart failure with reduced ejection fraction, because yes, because it cannot pump, so it will cause the systolic the heart failure. Yes. And then the another scenario is normal heart here. The concentric heart failure. So what that means is concentric the cardiomegaly. So it means that this one is the same thing, the size from outside, but this is like 10 centimeters, so 10 centimeters same. Now that the heart muscles grow inside toward the center. Okay, so it becomes like this. Heart muscle becomes big, right? So that's a good thing, right? Because the heart muscle becomes a good, big thing, thick. So you can have a stronger contraction. Problem is it grows inside. So instead of like a huge the opposite of like this, the eccentric heart failure, you have a huge chamber, right? A lot of the blood coming here, which is good. But problem is heart muscles becomes weak. You cannot pump this out. You cannot handle this out over his capacity. But now problem here is you have enough the strong muscles, but because of that strong muscle, you are sacrificing this space. Only tiny bit of the preload comes in. So what kind of? But problem is, okay. The question is, if you have this tiny the preload, right? Preload decreases. How about you pump out? Pumping out is okay because the this the preload is the preload reduced, but pumping out the outflow ejection fraction will be good too because you have a strong the strong heart muscles. You can ejection fraction is good. So this is called heart failure with preserved the ejection fraction. Okay, so this diastolic the filling problem. Okay, distinguishing this is a super important. Okay, so normally this is called restrictive the restrictive heart failure. Sometimes it's called the other one is like a diastolic. I mean, it's eccentric heart failure. Restrictive heart failure is the normally caused by losses, amyloidosis, hemochromatosis, that kind of thing. So that will make the muscle thick, but that muscle is although this muscle is thick, some part is muscle is not really muscle fibers. It's kind of amyloid deposit here. So so amyloid is like deposit here, normal and amyloid mixed. So although muscle becomes thick, it's not really useful. Okay. But anyway, so the problem there is like the your chamber will become smaller, tiny. So you cannot fill. Okay, that's the problem. Okay, in both cases, not good. But whether it's affecting the systolic function, where it's affecting diastolic function. That's distinguishing point. All right. All right. Now then, the so growth hormone deficient in its opposite situation. That caused the that caused the like the basically tiny human. So like the dwarfism, right? Okay. So another thing is also you need to know is we discussed this like hypoprolactinemia, right? So it can cause application bitemporal hemianopsia. Also the dopamine and the relationship. This one very important. Okay, and then the like that relationship is super important. Okay, hypopituitarism. This is also important thing. So, do you know? Have you heard about Sheehan syndrome? What happened is that uh, there are there are other symptoms too, but of importance is I mean all of this is important, but this is very important because this is the very well detected and then very favorable the exam questions too. So what happens is usually postpartum hemorrhages when you deliver the baby and you have like the very I mean kind of the popular the exam question is like this. the problem will be like this. The one maybe 25 years old female had some complication during the delivery, and then she had the postpartum hemorrhage. So postpartum hemorrhage means the postpartum. So after delivery, she has a lot of hemorrhages. So typically, it occurs. I mean, of course, there are many other symptoms, many other causes, but for instance, this is a uterus, and then this is a cervix, and uh, this was like the placenta, right? If this was the if this was like a uh, if this was like the all of a sudden this becomes like the detached placenta detached. How do you call that? It's called placenta the abruption. Yes, it's a postpartum bleeding, but this particular scenario, placenta abruption, is just abruptly, suddenly, this detached, okay? Placenta abruption, or that's one thing, that's one of the causing. Another cause is that this is a uterus, and then the placenta was supposed to be, placenta is kind of here, and then normally it's supposed to, baby comes out here, and when the baby come out, and then placenta is also kind of detached here, and then come out. That's normal scenario. Okay. The problem is if the placenta here, placenta is like the functional the uterine layer, which is kind of endothelium layer. Okay. And then this is the muscular layer, which is a big, and then epithelium layer. Okay. Now, the placenta supposed to be finished, the attached to here only, right? But if the placenta attaches deeper like this, or even deeper like this, the placenta is like this. What's going to happen is that when the baby lies here, and then baby grows big, and then baby now it's come out. Baby comes out. Okay, so this is opening here, vaginal opening here. Baby comes out. Placenta is supposed to come out, right? The problem is placenta cannot come out because it's like attached to the muscle. Muscle is like, if you attach to the muscle, if you pull out something, say you have something scabby in if you get maybe some cut or something, and then you have some scabby forms in the on top of the skin, right? And then as it get old, and then it'll easily fall off, right? That's normal situation. But suppose that the scabby is not right there, but it just makes a big scar, and then it just goes into your muscle. Will it come out? No, it will not. It will just attach it there. So muscle fiber, it will just placenta is like this, and then this part is attached to the muscle. It will not come out. So if you forcefully pull out, it will give big blood, big bleeding. So it's very dangerous situation. In most of cases, you gotta do the hysterectomy. So you take out the uterus, and then you cannot have a baby anymore. Very serious condition. Okay, so you have to see from the ultrasound that, oh, the placenta is here. If you after the bleeding, after the delivery, if you see still a lot of bleeding, too much bleeding, then you gotta check, oh, is this a normal placenta? If it's not normal, if it's like the invading the whole the like muscular layer, then you have to do because no other way that the take out only this part, because it becomes like attached to the muscular layer too much. Then you gotta do hysterectomy. You gotta take the uterus. No more bleeding. No more baby. Okay. So anyway, if you try to pull out the placenta forcefully, that will make a big bleeding. Okay, that's a serious condition. Okay. Anyway, that whatever the reason is, you get a lot of bleeding. Then what happens is listen this part very carefully because this will be on the exam. Pituitary here. Normally, say pituitary this side during the pregnancy. Do you think the pituitary cell will become this or this pituitary size during the pregnancy? Obviously, during the pregnancy, pituitary becomes big because you have to make more protein. More the more endocrine, more hormones, and for the to the baby and to your other placental functions, or keep the pregnancy and all other things. Your body need more hormones, so it will become more the hormones, then it will have to make more more production. So pituitary becomes big, right? Not this, right? And then the baby comes out. Then so it will, if it becomes big, means that more blood vessel, right? More blood vessel supporting the supporting the pituitary, big pituitary, right? And then when the baby comes out, you had a lot of bleeding. You are now hemorrhaging. So now at this time, you have a less blood left in your body, right? So basically, you are anemic. Now you have a less blood for supporting big the pituitary. So what's going to happen into this pituitary? It's a double effect. Even if it's normal blood, if it's big pituitary, you will have a problem supplying whole pituitary because pituitary became big, right? Now it in further, now we have a anemic conditions because you bled too much during the delivery, right? So you became anemic condition. You cannot supply enough blood to the pituitary, to new big pituitary. Okay, listen very carefully. New big the pituitary cannot be supplied by anemic the blood. Even if normal blood, it will have a hard time. If anemic condition, this double effect, double bad basically, right? So your pituitary becomes ischemic damage. Pituitary ischemia. So then everything in the pituitary will be down, right? So what's the most sensitive the gland in the pituitary that will be first go down, first the experiencing the ischemic damage? I told you prolactin, right? Prolactin is not there. Then what's going to happen? Prolactin is not there. You cannot lactate. The milk will not come out because you don't have milk. So, and then also prolactin is not there. And then also if it's prolactin is not there, also it's not the only prolactin gland. There's like the FSH and LH. All other things will be the go down, right? If FSH is not down, so no ovulation and no mens, right? So very typical scenario in the exam will be after the delivery. The delivery was complicated by postpartum hemorrhage, and the 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 lady tried to like lactate, but the milk didn't come out. And then also she hasn't had any the menses after that. So what's the problem? That's called Sheehan syndrome. Okay, so that's very, very important the condition. All right. So the another condition is like empty cellular syndrome. This is kind of the congenital syndrome. and then pituitary apoplexy, and those are all. This apoplexy is like basically apoplexy means like hemorrhage. Okay. And then craniopharyngioma. That's also the you know for the babies. I mean children. And then it's a Raske pouches tumor. Okay, so that's all make the compress the pituitary, and that then makes the problem. All right. Another important point is that this will be very important too. So if there's a thyroid, you know this thing, right? Thyroid growth the duct. So it's supposed to be, you have to know this one. Foramen cecum is the origin, and then it just goes down here. That's the thyroid gland descent. Okay, and if that's not descend properly, what's going to happen? There's there's another kind of gland like this thing. Okay, but still, and then after it descend, this will be just normally this disappeared, but it's not the disappearing, and then still remains there. Yes, 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 it remains there. It's a it becomes like diagonal duct, and then it becomes like a cyst, or it's just sometimes it's just a non. Most of the time it's just a cyst and then non-functioning, but it's still there. Okay, so that's a completely benign condition. But sometimes it secretes the thyroid the thyroid gland. I mean the thyroid hormone T43. Okay, sometimes it does. Okay, the main thing is that because this thing is connected to it. So what happens if you swallow? Your tongue will be goes back, right? Goes back here, right? Tongue will goes back. Then this will pull up or pull down, right? So as you swallow, this will move back and forth. That's the difference between if there's something else, like it's not in the due to the thyroglosal duct. If there's some kind of tumor or something, just other than this the thyroglosal duct, if there's some other tumor, anything can happen, right? So if there's a tumor, lipoma or something else, then this this differentiation point is that if you swallow, this will not move. If it moves, that you will see that, oh, there's something to do with the foramen cecum, because foramen cecum was origination of the thyroid gland. So if you, there's like a line here, line. So if the line, this line is supposed to disappear. So the thyroid gland right here. But if it's not disappearing and then it forms a like cyst or some kind of like extra thyroid gland, then it will move as you swallow. The reason that this is moving is because of this the connect to the foramen cecum. Foramen cecum is like very on back of your tongue. That you will see the tongue is like this. Then there's like a kind of this, and then there's this point. It's called foramen cecum. Okay, so it will when you swallow, it will move. So that's the problem distinguishing point. Okay. So, they usually ask you, what's the like, why, what's the origin of this that thing? So you say the thyroid grosser duct, and then you distinguish between this another tumor. Okay. Another important point is that parapituitary and parathyroid are the hormones gland. Parathyroid gland is para means next to the thyroid gland. So thyroid gland is like this. Then parathyroid gland is back posterior. That's important point. Posterior of thyroid gland. Para means para is next to, actually next to, but posteriorly located. Okay, posteriorly located foregland. That's the parathyroid gland. Okay, so like this is a very, very common question. What the branchial what kind of the parenchymal what level of the parenchymal pouch, parenchymal cyst is the constitute the parathyroid hormone gland. Third and fourth. Okay, third and fourth. And then what's more important is that 3 and then 4, right? So what happens is that this is kind of really kind of the tricky point. So parathyroid hormone, parathyroid gland has like 1, 2, 3, 4, 4 glands, right? So inferior and then superior, right? So inferior is supposed to be, normally, like 1, 2, 3, 4, 5, 6. Then the 3 is top, 4 is the bottom. That's normal situation, right? But this one is kind of little the exception. That this is a third pouch, and then this is a fourth pouch. So that's kind of something that you need to know. All right. So this is all kind of the med one materials, med two materials, yeah, med two materials. But you need to know this, that this thing will come out. Okay. Yeah, this is what I just explained here. All right. And another the important point is that there's a the basically the hyper or hypothyroid gland, right? I mean thyroidism, right? So I'll just highlight the key point that you have to know. Okay, so Graves is the hypothyroidism, most common cause of hypothyroidism. Two things you need to know: exophthalmos. I forgot the name of this. It's like eye pops out like this thing.
Exothalamus.
Yeah, yeah, exophthalmia, something like that. Okay, so that thing, and then also the uh anterior shin, anterior shin. So in the anterior shin, you will see the like you will see a pretibial myxedema, and both are, listen carefully. This is an important point. Both are what causes this. That's the important thing. Okay. The glucosamine, the GAG, glucosamine amino, the glycoside, something like that. Okay. So this is what's growing. This is kind of fibroblastic growth factor or something like that. Okay. So this will cause this thing, the GAG, back of the eye, and then back of the like just next to the anterior of the pretibial area. That's what makes the pretibial myxedema and then exophthalmos. Okay, so those things are GAG. So those things will be on the exam. And then also, what's the important thing in here is that uh, where is it? Yeah, it's coming here. Okay, and then what's the important thing is that what's the problem? So basically this is like autoimmune, right? Autoimmune means, what does autoimmune mean? Autoimmune simply means auto, self, immune, meaning that what this means is that your antibody, your body's own antibody, is supposed to like against some attack against your some antigens, right? That's supposed to be normal function. But what happens is in the autoimmune diseases, that your antibody that is supposed to attack the pathogens, it will attack yourself by mistake. So autoimmune is mistake, basically. Mistakenly attack yourself. Yourself. That's autoimmune disease. Okay? So in this case, antibody, right? Attacking you. What this is attacking is very important. TSH receptors. So I will just make it here. TSH receptors. Not This is a distinguishing point from Hashimoto. We learn hypothyroidism. Okay, Hashimoto PTO. I mean, the parathyroid. Let me see. PTO is the peroximide. The P. Let me see. Hashimoto, right? Just a minute. Thyroid. The Hashimoto. Where's the Hashimoto? Is autoimmune condition. It's the yeah, right there. Hashimoto is a TPO, sorry, PTO. So this is a TPO, but this is a TSH. Okay, that's the important point. Yeah. TSH. So antibody against TSH, meaning that antibody means that the IgG against TSH. TSH is important. Okay, so that's the important point about the Graves. Graves, all you need to know is like antibody against the TSH, and then these two conditions, ophthalmic hyperplasia, and then I mean the exophthalmia, and then also the peritibial myxedema. Those two are very, very important points. That's a distinguishing point for the Graves, unique distinguishing point. Okay, and then antibody TSH, right? And that's about this thing. And then the treatment. Yeah, I will come back later for the treatment. And then there are other the other diseases that causes the goiter. Goiter. Don't worry about goiter. Goiter can be hypo, doesn't matter. Goiter simply means a big thyroid. That's it. Okay. When it becomes big, that's a big thyroid. Another important point here is also this thing. So how thyroid hormone will be made. So you basically it made of iodine. Okay, iodine uptake, and then in the follicular cell. Okay, and then it will cause, it will be the first uptake, and then oxidation. Oxidation means it was when you uptake anything from your blood to the cell, it has to be ionized to uptake. So I minus, or Na plus or K plus, something like that, right? Otherwise you cannot uptake. Okay, so you uptake, and then it has to, when you do when you process to make the this is the factory. Okay, this is a kind of reception desk. Okay, so reception desk, you come into the factory by enter the this facility through the reception desk by ionized form. Okay, when your ionized form comes in, you go into the factory oxidized form. Oxidized simply means like instead of the ionized form, it becomes I2. Okay, oxidation. Okay, then it will become organification. You have to know this thing: uptake, oxidation, organification, coupling. Okay, organification simply means that it will add with the I2, so two I2s or the one I2. The one I2 means like the MIT. Two I2 means DIT. Okay, and then it will combine with thyroglobulin. Thyroglobulin will bind with this or this. Okay, so it will make the thyroglobulin bind with this. So it will make MIT DIT. Okay, so then the one good thing is, one easy thing is like all this the hormone that I mean enzyme that stimulate this process, all this process is by TPO. Okay, that's easy, right? So TPO will do this. All this is a TPO. All process in the diode the making process is all TPO only. Okay. Then the coupling means that MIT and DIT is made, right? Now MIT, I mean MIT DIT with 3, 1, and then 2 is a 3, right? So T3. DIT plus DIT is a 2, 2 is a 4, right? T3 and T4 made. Okay? Then it will just release through the body. Whereas release through the body, it will, some of them bind to the diode binding globulin and bind to T4 or T3. Okay, and some of them are free form. Free form means just a T4 or T3. Okay, free. All right, and then another important point is that let me see, where is it? Okay, another important point is that what will inhibit this each of this process. That's a very 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 important. The let me see if there's any picture for this. Very very important. I think there's a picture in somewhere here. Okay, if not, then I'll just explain it in here too. So the drugs that works in here, so you come out. Oh. So when this come out, it will bind to the T3 and T4, right? So here, right? So this one uptake, and then this one is inhibited by the PTU and then MTG, metimazole, PTU, thirourethrin or something like that. Okay, PTU and then MTG. Those two are the called thioamide. Okay, so this will inhibit those processes. Okay, but problem here is that PTU both are actually the not good the a lot of side effect, but more severe side effect, especially for the organogenesis, will be occurred by the PTU. PTU has a more no, I mean the MTG. MTG has the more serious problem. So during the first trimester of pregnancy, use PTU. Okay. Then after the first trimester, you can switch to the MTG. Then second trimester and then third trimester, use MTG. Betimazole is a MTG. PTU is a the P2 I forgot the name, full name, but it's not important. They will say PTU or MTG. Okay, so that's important thing to know. And then also another thing is that when this comes into in the free form, there's a T4 and then T3, right? T3 is a more active form, so it will turn to whenever T4 is like an inactive form. Actually, it's the more active form. Not I said more active. So T3, T4 both are active form, but it's a T3 is more active form. So okay, so it will be converted by I mean this conversion is inhibited by beta blockers. So that's the kind of strange, right? Why? What the heck is a beta blocker? Is it? So that's the important thing. But this is due to GS pathway. So something you need to know this one. Okay. So those are the key point here. Okay. So you need to know uptake, oxidation, organification, coupling, the release. This order, the order will be on the exam. Okay, order you need to know, and then also what drugs if you are pregnant, you use, if you have a hyperthyroidism, PTU, okay, and then switch to the second and third semester, you switch to metmazole, okay, and then the beta blocker will inhibit T4 to T3 conversion. That's all you need to know in the thyroid hormone. There is another thing. It's called Wolff-Chaikoff effect, and then Jad, the Vasilov. This one is kind of opposite. Wolff-Chaikoff is too much. The iodine will cause the. It's supposed to. If it's suppose kind of. If it's too much iodine, then you will have the more the thyroid gland, right? But it this will cause like hypothyroidism, opposite. And then Jad Besto is the opposite of the Wolff-Chaikoff. Okay, so that's all you need to know, because it's not really because the this is kind of you if you have too much of this, too much of iodine, then your body will kind of react to protect your the thyroid gland, so that you don't make like too much iodine. I mean too much thyroid gland. Sorry, too much thyroid the hormones. Uh, by just to protect the thyroid gland itself. Okay, so actually, this is both of these mechanisms is kind of the real mechanisms are unknown. Okay, so they will not ask you what's the mechanism of this, but they will ask you, what's the cause. I mean, what it will cause. It will cause. I mean, it will cause like hypothyroidism for Wolff-Chaikoff, and the other one is hyperthyroidism in the Jad Besto. Okay, so it's opposite. Okay, so another thing you need to know is that uh, thyroiditis. Thyroiditis is means that uh, itis is an inflammatory condition. So in other words, it will be inflammatory condition. In this case, is mostly acute. Okay, so this is a inflammatory condition that will make a big thyroid hormone surge. Okay, very big. The all of a sudden becomes very big thyroid hormone. That's what the thyroiditis is. And then one of the big thing you need to know is that Hashimoto is a thyroiditis. It will cause hypothyroidism at the beginning. So Hashimoto, the thyroid is basically what this is. Hashimoto is supposed to be hypothyroidism, right? But what happens is that the reason that it becomes a thyroiditis at the beginning, initial, is that it will leak out. It will leak out all this the thyroid made inside of this factory. Okay, leak out from the factory is causing temporal thyroiditis in Hashimoto's disease. Okay, Hashimoto is the hypothyroidism. Okay, and then subacute is also important, because most of the time, all other conditions in the thyroiditis I mean thyroid conditions, we will never cause pain except the Decabian pain. Okay, that's you need to know. All right. Another important point is drug induced, meaning that, do you know amiodarone? Amiodarone. Amiodarone is one of the anti-arrhythmic, right? So amiodarone, IOD, that's iodine. So because of this, it contains the iodine, it has a problem. So iodine, you think about the thyroid, right? So because it has iodine inside, so it causes some problems thyroid. So before you, what's important in the question purpose and also in the clinical is, before you prescribe the amiodarone, you have to do 3 tests: thyroid function test, pulmonary function test, and then heart function test. I mean, of course, there's no such thing as heart function test, but it's this is what I the try to memorize. Thyroid function test, because you have to see if he has a like, normal thyroid function. Otherwise, it will cause it will, it can also cause the hyper or hypothyroidism. Okay, but if this is supposed to be normal, and then also amyothyroid is also famous for causing pulmonary fibrosis, very serious condition. Okay, so you have to test whether your the lung function is okay. Also, it can cause the cardiomyocytes. So you have also check the heart function. Okay, those three are very important. All right. Okay. Uh, there is also very important thing in the pregnancy, but this will basically during the all you need to know is thyroid binding globulin will be increased during the pregnancy. Okay, so as the sex hormone binding globulin SHBH, the sex hormone binding globulin is also increased during pregnancy. So this something you need to know, all right? And then if that's happening, then what happens is free the thyroid binding globulin level. Thyroid binding globulin will bind to the T3 or T4, right? So this binding globulin will be reduced. I mean, will be increased, but T3, T4 levels relatively unchanged. Okay. So the question will be. This is a very good question, very famous, popular question for arrow question, whether it's going up or down. You will have to say free T4, T3 will just normal, not high or low. Okay. Because this is kind of, this is a little bit the ambiguous point, as in SIADH cases. This one is like, why is it the free? I mean, free T3, T4 is normal instead of, because you have a more binding, then it'll have supposed to have a less, right? So that's what what many people think, but it turns out that because it's nobody knows really why exactly, but the what I can explain to you is that because the thyroid gland has a lot of storages here. So if there's like some T3, T4 low, then it will secrete more T3, T4. Okay, so that's why this becomes normalized. Okay, so you need to know this, right? This is very famous and popular the arrow question. Okay, all right, and there are some the let me see, neoplasm is very important too, but we have since the time is almost up, so I want you to read this. But the another thing very important is that let me see. Hyperparathyroidism. Okay, hyperparathyroidism, primary, secondary, tertiary. All right. So primary is always primary. Think about the gland itself. So parathyroid hormone. So what's the gland? Parathyroid gland, right? Parathyroid gland has a problem. That's the primary parathyroid hyperparathyroidism. And then when the if it's a gland problem, then primary. If it's a one level up, that's the secondary. Okay, and then tertiary usually is a kidney injury, kidney fail caused the tertiary. Okay, that's what you need to know, right? So when the tertiary occurs, tertiary hypoparathyroidism occurs, kidney fail. So kidney fail means that the question will ask you, what's the vitamin D level? If the kidney fails, vitamin D level will go down. Okay, that will be a cause of the parathyroid gland to make more parathyroid hormone. Okay, I think that's the one cause. And oh yeah, another this important thing. familiar hypocalcemia. Basically, this is a calcium sensing receptor problem. Okay, so that's what you need to know. Even if low calcium level, in this particular case, it will just detect, oh, yes, there are too many the calciums by mistake. It will detect that. Okay, so mistakenly, that's the problem. All right. Another thing is that I think those are the other ones. You can read it by yourself, and then we'll continue with we'll stop here for the morning sessions, and then we'll continue with 1 o'clock. Okay. All right. Thank you very much, and we'll continue with a little bit of a pickup from the this chart, and this is very super important. And then we'll continue at 1 o'clock. So please leave this channel so I can because otherwise it will just I mean override the recording to the previous recording. So just leave this channel. Everybody leaves this channel. Okay. And then we'll meet you. I'll see you at the 1 o'clock. All right. Thank you. Please leave this channel now, and we join at 1 p.m. Thank you. Mm.